Good morning, everyone. So first of all, I thank the organizing committee for giving me an opportunity. I'll be talking on the minimally invasive spine interventions. So these are the learning objectives for this talk. I won't be going to the technical details of each intervention. The most important take-home message would be from this discussion, whom to prick and whom not to prick. Okay. So the interventional pain management, where does it fit in the management of chronic pain? It has to be considered as a component, as one component of a multimodal, multidisciplinary approach to chronic pain. It is not a one-stop magical solution for patients suffering from chronic pain for 5 years or 10 years. These patients require a holistic approach to pain management. And what are the advantages of intervention? It provides faster pain relief. It breaks the vicious cycle of sensitization. We all know the harmful effects of sensitization. So it breaks the vicious cycle of sensitization. Then it provides a better response to medications and a better rehabilitation program. And one less talked but important advantage of intervention is that it serves a diagnostic purpose also. It helps to identify the pain generator. Chronic pain, especially low back pain, is like an invisible illness. Patients come to us like suffering from back pain for 5 years or 10 years. They will have 5 MRIs with them. All the imaging studies, investigations are normal, but the patient is suffering in pain. So we physicians tend to think or tell the patient that it's all in your head. Am I right? So here one thing that we should know is many pain generators of spine, we cannot pick them no matter we do n number of investigations. So that is the importance of a diagnostic intervention. So when to consider intervention? The only indication for an intervention is the presence of pain. Whether to consider an intervention early or to later after all the conservative measures have failed, that is a choice the physician and the patient has to take. The only indication is the presence of significant pain. But we should always rule out red flags. Yellow flags, orange flags, that is psychological components, should be addressed early and properly. So I'm not going to into this detail because it has been already discussed. Red flags in low back pain. If red flags are present, the patient should be thoroughly evaluated before we proceed for an intervention. Now, this has also been discussed, but in young patient, that is around 40-45 years till that, the most common cause of back pain is discogenic pain or internal disc disruption. In elderly patients, like after 60-65 years of age, the most common cause of low back pain is facet arthropathy. Then, all the patients who come to my pain clinic says, doctor, they will show an MRI and say, I have a disc bulge. This is the cause of my pain. But actually, the prevalence of a disc herniation causing radicular pain, the chance is only less than 5% of all low back pain cases. Then we have canal stenosis in elderly patients causing neurogenic claudication. Then the rheumatologist, you all know about this, sacroiliitis, SIJ, and of course, myofascial pain. So these are the common pain generators, and we are going to discuss the interventions for these pain generators. So my first case is a 30-year-old male who had low back pain radiating to the lower limb, right lower limb along the L5 distribution. And the leg pain was more than the lower back pain. He had neuropathic features like numbness, tingling. The pain worsens on standing and walking. He was comfortable while lying down and sitting. There were no red flags. So this patient, and on examination, his SLR was positive, and this patient had an L4, L5 posterocentral disc bulge with compression on the right L5. So the surgeon advised conservative management because only 1 month duration, no red flags, but the patient was in intractable pain. So the choice of intervention here is obviously the epidural steroid injection. So here I have used a transforaminal approach. That is, we are approaching the epidural space, the anterior epidural space through the foramen, intervertebral foramen. So we can see the dye outlining the right L5 as well as the S1 nerve root. Now, which all conditions an epidural steroid is indicated. The most importantly, it is for disc herniation causing radicular pain. Then we have spinal canal stenosis causing claudication, failback surgery syndrome, in which there is residual disc bulge or recurrent disc bulge, there is a role for epidural steroid. And as ma'am discussed in the previous talk, if there is epidural scarring, that is epidural fibrosis, there is role for caudal neuroplasty. In caudal neuroplasty, apart from local anesthetics and steroids, we use hypertonic saline and hyaluronidase to break down the adhesions. And then there are some miscellaneous causes. Now, does the route for the epidural steroid matter? We have three routes: transforaminal route, interlaminar, and the caudal route. So, for disc herniation causing radicular pain, transforaminal route through the foramen, transforaminal route is considered far superior because we are injecting the drug close to the site of pathology, lower volume of drug is needed and lesser amount of steroid will suffice. But there is a potential complication here. Even though it is extremely rare, it's a disastrous complication because in the foramen, apart from the nerve, we have blood vessels also. Especially if we are doing at the level of L3 or above, our needle may encounter the artery of Adamkimeves, the major radicular feeding artery. So in that case, it can lead to spinal cord ischemia and paraplegia. It's a very extremely rare complication. But for that matter, the recommendations for safe epidural is that we target the lower part of the foramen than the classical subpedicular approach in we target the upper part of foramen, go to the lower part of foramen, and also at the level of L3, at least at L3 or above, use non-particulate steroids. The problem with particulate steroids like triamcinolone is that the particle size is more and it will embolize. If it is accidentally injected into the artery, it will embolize and cause spinal cord ischemia. So at least above L3, go for dexamethasone, non-particulate steroids. The efficacy is almost the same. Now the evidence, overall for disc herniation, the epidural has got good evidence. Duration of pain relief, 6 months to 1 year. Shorter the duration of symptoms, better the results. That is why you should refer to an interventionist early. No impact on the overall incidence of surgery. And the evidence is less promising for canal stenosis and good evidence for caudal neuroplasty in failback surgery syndrome. So now we go to the second case. This is a 65-year-old male who had low back pain, and it is radiating the posterior thighs in this manner for 5 years. So this patient, the low back pain was more than the lower limb pain. He had no neuropathic features. His pain worsened on standing for some time, lying down for some time, and he has some stiffness in the morning. And there were no red flags. So this patient, MRI did not have any significant findings, and he was even asked to consult a psychiatrist. But considering the age and the clinical, on examination, there was paramedian tenderness, and as sir discussed in the first talk, the facet maneuver, the extension and lateral rotation, the facet maneuver was positive. So considering that, a clinical diagnosis of facet arthropathy was made, and this medial branch of dorsal ramus, diagnostic block and RFA was done, and it is 1.5 years now and the patient is doing good. So that is the importance of recognizing facet arthropathy, and it has got good evidence. The radiofrequency ablation has good evidence for facetogenic pain. The North American Spine Society, the evidence-based guidelines, they say that they recommend thermal RFA for facetogenic pain with moderate strength of recommendation, but the diagnosis has to be correct. For that, we should know that we cannot identify facet as a pain generator in any of the imaging studies, be it CT, MRI. All MRIs will show some facet hypertrophy, but that doesn't say that facet is the pain generator. The only way to identify facet as the pain generator is to give a diagnostic block and then proceed for RFA. And my third case is a 48-year-old female who underwent lumbosacral fusion 1 year back. And after the fusion surgery, her radicular pain subsided. But 3 to 4 months after the surgery, now there is a new problem, a new onset pain in the right gluteal region. So this actually qualifies as a case of a failback surgery syndrome. And the right gluteal pain was worse than the lower limb pain. The radiation of pain is shown in the picture. And it was an aching kind of pain that worsens on sitting, no neuropathic features and no red flags. So This is a case of failback surgery syndrome, and there are many causes for FBSS. Here in this case it is sacroiliac joint arthropathy. Her SIJ was tender and all the provocative tests were positive. So we should know that after a lumbosacral fusion surgery, the incidence of SIJ arthropathy can go up to as high as 40%. And not just for after fusion, for sacroiliitis we have two options. One is intra-articular LA steroid injection, local anesthetic and steroids, or to go for a radiofrequency ablation, that is denervation of the SI joint. And the evidence for SIJ intervention, if you see, cooled RFA, cooled radiofrequency ablation has got a better evidence. Intra-articular steroids, they are effective, but as we know, provides only short-term benefits, 3 months to 6 months. PRP, as of now, evidence is lacking. Now, my fourth case is a 34-year-old female. She had right gluteal pain radiating to the leg in this fashion for 9 months. And at the onset of pain, she remembers there was some trivial trauma, and her pain score was 8 out of 10. Her gluteal pain was more than the lower limb pain, and it was an aching pain predominantly, but occasionally there were paresthesias, numbness, tingling. And this pain worsened whenever she sits or lies down on the same side, and also there was some pain while standing and walking. There were no red flags. So this patient, the MRI was completely normal because 34-year-old female, no degenerative changes, MRI was completely normal. She has a history of twin delivery 1.5 years back. So she was diagnosed as postpartum depression, and she was even started on medications for that. And there was one orthopedician in our hospital who suspected there is some gluteal pathology in this patient and referred the patient to me. And on examination, there was marked gluteal tenderness. SIJ was negative and SIJ tests were also negative. But this test was positive. This is flexion, adduction and internal rotation, the FAIR test, which is positive for piriformis syndrome. So piriformis is a muscle that exits the greater sciatic notch and gets itself attached to the greater trochanter or femur. Under the piriformis muscle travels a sciatic nerve. So when piriformis goes into spasm or there is damage to the muscle, obviously there will be sciatica-like symptoms. So I don't know whether the video will play. Sorry, the video is not playing. Yeah. So this is the gluteus maximus and this is the piriformis muscle. My needle tip is here. Just like I said in the beginning, the targeted injection, ultrasound guided targeted injection into the piriformis muscle will make us clear whether that is a pain generator or not. So this patient, after the first sitting, she was relieved of her symptoms 70%, and after the second sitting 1 month afterwards, she is completely relieved of her pain. So what we have to be careful while injecting in the piriformis is the sciatic nerve. It passes below the piriformis muscle, and in some patients above. Anatomical variations are there. So if you are not careful, you can cause an injection neuropathy. Then the last case, sorry, not the last case. Then when we discuss the myofascial pain, we see patients like this also. Back pain, predominantly a flank pain. And the patients say that my pain worsens while I cough, sneeze, turning in bed, lateral flexion, etc. So this is a case of quadratus lumborum myofascial pain syndrome. I had a patient who was investigated for renal pathology because he repeatedly came to the OPD and told the surgeon flank pain. So CECT was done, USG was done, but it was actually a case of quadratus lumborum myofascial pain. So this is the quadratus lumborum muscle attached to the transverse process of the vertebra, and this is the iliopsoas. So the needle will come from here and we can inject the quadratus lumborum myofascial plane. We can, if the iliopsoas is involved, we can inject here also into the psoas. So for evidence for piriformis syndrome, local anesthetic steroids, botulinum toxin, everything has been found to be effective. In refractory cases, we go for botulinum toxin injection. And the last case, this is a case of a 60-year-old female. She had upper gluteal pain radiating to the lower limb in this pattern. So her gluteal pain was almost same as the lower limb pain. She had paresthesias also, and on examination, Just 2 minutes. On examination, there was mild compression on L4, L5, nothing significant. SIJ, FSAT, everything was negative, no myofascial trigger points. But on the iliac crest, almost around 5 to 7 centimeters from the midline, we had a Tingle sign positive, classic tenderness on the upper part of the iliac crest. So this is a case of cluneal neuralgia, a very much underdiagnosed cause of low back pain. So I'm not going into the details, but you can refer to this article which came in Orthopedic Reviews for understanding cluneal neuralgia. It is an underdiagnosed cause for back pain and it presents as sciatica-like symptoms. So the take-home message is that the intervention should be considered as a component of a multimodal, multidisciplinary pain management strategy. Most important aspect is to identify the pain generator. Right intervention for the right patient is important. And the realistic expectations. The patient should be given realistic expectations. Even 30 to 50% pain relief is considered as a treatment success in chronic pain patients. So we all know the consequences of chronic pain like this: physical, decreased physical functioning, psychosocial issues, financial burden. But a new research is coming up that chronic pain leads to gray matter volume loss also. So it causes accelerated aging. So it's important that we treat early and treat well. Thank you.